You're visiting your mom for dinner when she mentioned she's been experiencing some mild heart palpitations. Like many people, she hates going to the clinic and it's a challenge to get her to see a doctor. You know, there's been recent developments in mobile technologies that can screen heart conditions at home. Maybe that could work for your mom. But how do you know she'll keep at it or that she'll get the appropriate care if something happens? Dr. Cam Wong's study is titled Patient-Led Mass Screening for Atrial Fibrillation in the Older Population, using handheld ECG devices integrated with the clinician-coordinated remote central monitoring system. Let's break that down. Patients are screening themselves for atrial fibrillation at home for the first time ever. Think about the reach and scale of cardiovascular monitoring if patients could do it themselves. Second, the most at-risk patients are age 75 or older. What does an easy-to-use technology look like for this group? Third, how does a handheld ECG device compare to what clinicians would normally use? Dr. Wong's work delivers practical results in remote patient monitoring of heart rhythm of this at-risk population through a simple single lead handheld ECG device.
So if you wait for the doctors to do a formal 12-lead ECG trace on the patient, it takes about 5 to 10 minutes to get the patient, prepared, go to the couch, lie them down, put the 10 electrodes correctly on the body. So that is very time consuming and not practical because if you're going to do it across the board, right? So it ends up at the moment, it's all non-mandatory, it's all opportunistic, up to the clinician. And the clinician face a lot of competing priorities in the work, time pressures in busy clinical settings. If they have that little device, they may ask you to hold it for 30 seconds and see what it shows up. But a lot of people, they are not adopting this digital health technology at the moment. So this leads us to think about how to take all this away from the clinician and how can we pass this task, these routine things to patient to let them do it on a daily basis as a habit.
We've all been living through the pandemic and everything has gone virtual, including clinical trials. Dr. Wong brings unique expertise in engineering, applied statistics, and 16 years of medical practice to his passion around expanding healthcare access through digital measures. His recent work includes research on user experience and accuracy of handheld ECGs. His interest in remote cardiovascular monitoring was inspired by a magazine article.
This person called Paul, he described about some symptoms, which is very vague. He played rock and roll band. He was 67 years old, and he had a strange feeling in his wrist one day, and he didn't take it seriously, and ended up he had a stroke actually, and presented to his doctor, and was diagnosed with atrial fibrillation. So a lot of people like this person do not know that they got irregular heart rhythm and ended up they present with a stroke.
Atrial fibrillation, or AFib, is a fairly common heart arrhythmia in older people. AFib is reported to account for 36% of all ischemic strokes, despite the wide availability of anticoagulants to reduce risk. This study is a two-armed randomized open-label waitlist control trial in community-dwelling people aged 75 or older. Randomization occurs at a 1-to-1 ratio, stratifying participants by frailty status. The intervention group is monitored for 12 months upon enrollment. The control group is waitlisted for the first 6 months, then monitored for the following 6 months. This trial design presents an interesting opportunity to put the patient first in delivering care.
Being a waitlist control is quite different from just a randomized control trial, because a lot of time, randomized control trial, you do not involve the control subjects, right? They have no opportunity to participate at all. So waitlist control gives that equitable access to everybody. And one advantage is after they have been waiting for 6 months before they come on board for the next 6 months, it's good to check on them how they feel the difference, right? The perceptions and experiences while being waitlisted versus their experience while they are in the intervention program. So that bit of information, actually, we're looking forward to it, to say, do they feel that they're more being cared for when they're in the intervention?
This study has several objectives. First, we want to compare our ability to detect atrial fibrillation using the handheld device in the intervention group compared to the control group. Second, to evaluate the feasibility of the intervention, or is this type of patient-driven community screening even possible? Third, to consider how participants felt. Were they happy? What were the barriers?
Because of COVID-19, a lot of people are under lockdowns. They couldn't go elsewhere. They couldn't go traveling. So especially the elderly group. So they are in lockdown and they want to talk to somebody and they want to connect, right? So that is the best moment when we call them and sign them up, enroll them. So initially everything is done. They got email, they got text to the phone, they got every day do it faithfully or religiously, they do it. And they just wonder, are there people out there looking at those ECGs or not, right? And the protocol says, if your ECGs are normal, no one will talk to you. You are fine, right? So for those people who are very disciplined and do it every day, they do not hear from us and the ECGs are normal, they start to become anxious and say, am I doing right? Or are there people out there to check this? So when I talk to them, they are so happy to say, I'm glad that someone is talking to me. When you talk about virtual, there's advantage and disadvantage, in virtual trial, because you want to feel you are connected, you got more personal care from somebody. And yet, as a researcher or from a healthcare provider point of view, we want to scale up to reach to wider community, right? So it's a matter of balance between that personal touch that you give people and that scalability that you can reach out to wider community.
For the fields of remote patient monitoring, patient-driven screening, and virtual clinical trials, this is just the beginning of the radical changes coming to healthcare practice.
Once we have assessed the feasibility of this trial, this technology, regardless of device, is to see how can this be scaled up to reach a wider community, especially those people who live remotely or in isolated location, who are frail and who have problem to access to healthcare needs, right? So we cannot expect everybody turn up to your surgery to get checked on a regular interval. If we can have a cheap, affordable technology that can be shared and to this community, that will be my greatest hope. A technology and a trial that can reach to community who are in need.
To bring this story home, imagine the next time you see your mom, it's her 75th birthday. You mention how easy this at-home screening test is, and she agrees to try it out. Through regular testing at home, your mom is identified as having atrial fibrillation and is at risk of stroke. Thankfully, she was identified early, and her condition is managed with medication, avoiding the pain and challenge of managing neurological complications after a stroke. This is just the tip of the iceberg of what will be possible with sensor miniaturization, data modeling, and remote patient monitoring. Dr. Wong's protocol demonstrates a feasible and patient-centric approach to population health screening that has the potential to be delivered at scale for meaningful results. This is Dr. Jennifer Zhou, JMIR Ambassador. Be sure to follow us on YouTube, LinkedIn, Facebook, and Twitter.